Okay, and it started. Today we want to discuss some other concepts or extensions of time to event analysis or survival analysis, and that's the concept of competing risk and multi-state models. So we're going to talk about composite outcomes, what we mean by that, and then do a bit of review of time to event analysis. And we'll look at the concept of competing risk and then look at multi-state models. So, and I'm doing this primarily from the standpoint of cardiovascular research because it applies very well. So in cardiovascular trials, oftentimes the primary outcome is a composite of several events like death or non-fatal stroke, non-fatal MI, or revascularization. And so if you have several outcomes that you're combining, then occurrence of any one of the events would count as a yes in a dichotomous outcome. And so typically time to event analysis are analyzed, in this case, by Cox regression. And essentially, Cox regression is similar to linear regression, where you have a regression equation that consists of an intercept term and then one or more covariates that you think might influence the outcome. And so here, H sub t is the hazard function. And then so in a Cox regression, you have the baseline hazard function raised to the exponent of essentially the regression equation, or you can write it this way, where it's the constant E raised to the regression equation for a value for each individual patient. Sometimes this is the analysis involves a separate analysis of each event type, and then they're often referred to as secondary analyses, but we'll see that there's some issue with that approach. So to review time to event analysis, in medicine, we call that survival analysis. In manufacturing, they call it failure time analysis. But essentially what we have, and of course, I'm doing this from the medical standpoint or viewpoint. So we have, in this case, two outcomes. We have an event, which is dichotomous, either dead, alive, yes or no, positive or negative. And then we have a time to the event, which is a continuous variable. And so in terms of the time variable, we have to have a beginning and an ending time. And we also then have to account for what's called censoring. And censoring is the situation where we don't know exactly the survival time or the exact survival time of some individuals. And essentially what we want to do then is we want to compare the survival functions of two or more, say, treatment groups or therapy groups. And then typically, in most trials, we want to assess the impact of covariates, demographic and clinical variables on the survival functions. And this is why the Cox model is used most often in these analyses. So a little bit about censoring. Censoring occurs when a subject is observed for some period of time, but without the event of interest occurring. And the assumption that's made in the statistical analysis is that the censoring process is independent of the failure event. And so there's different types of censoring. The primary one that, or the one that you'll see most often, is what's referred to as right censoring. And this can be due to loss of follow-up, or the patient withdraws from the study, or maybe your study comes to an end without the event occurring for some patients. And then the situation where the patient dies, but it's from a cause other than the study outcome. So for example, if you're looking at cardiovascular death, but the patient dies in an automobile accident, say, for example, then that's really a censored information observation. And so this is an example here of what we mean by right censoring, a picture example here. And so in any trial, you have patients entering the trial at different times. So for example, patient number 1 begins at time 0 and is followed to the end of the study without an event occurring. Patient number 2 enters at time 0, but experiences the event, the terminal event, whatever that is. And then you have like patient number 3 and 4, they're entering the study at different times, so their follow-up time is different, and neither one experienced the terminal event. So patient number 3, sort of in the middle of the study, is either lost to follow-up or withdraws, or for whatever reason is no longer in the study. Now, patient number 4 continues to the end of the study without the event, and then the others you interpret the same way. And just let me point out, patient number 10 is followed to the end of the study without an event, but perhaps the patient experiences the event of interest after the study is over, but that is not counted in the analysis of the study. So even though patients are entering at different times, when we do the statistical analysis, everyone is sort of moved to starting at time 0, and then whatever their follow-up time is, we can use that time and use that information in the analysis, even if they're lost to follow-up before the end of the trial. So other types of censoring, interval censored, is the situation where we know the event occurred, but we're not sure exactly when it occurred, but we have an interval of time that we know it occurs sometime in that interval. And then left censored, which is actually more difficult to analyze, is that we know that there's an event and the time of the event, but we're not sure when the beginning time is. And as I mentioned before, in survival analysis, you have a beginning time and an end time. But not knowing the beginning time, there's a way of analyzing that, but we're not going to, those are separate topics that we're not going to cover today. So the survival function is defined as the probability of surviving longer than time t. And so the function is the probability of survival given the time at which you're looking at the patient and patients at one particular time, and then it's the probability that they survive longer than that specific time. And so the calculation is just the number of patients surviving longer than t divided by the total number of patients alive at time t. So we then also can define the hazard function. And so in contrast to the survival function, which was the probability of surviving beyond time t, is the probability of the event occurring at time t, or we also call the hazard function the instantaneous failure rate. And so that's when we look at graphs, which you typically have, or almost always have in survival analysis, that's the cumulative hazard function. And the hazard function and the survival function are related. If you know one, you can calculate the other. And so, as I mentioned, the survivor function is the probability of surviving longer than time t. Hazard function is the probability of dying at time t, or the event occurring at time t, and it's the derivative of the survivor function. And so, as I mentioned, you can, if you know one, you can calculate the other. So let me give you an example from the simplest survival analysis using what we call the Kaplan-Meier method. I do this because this is really simple to calculate. When you have multivariable analyses like in Cox regression, it's obviously a little bit more complicated, but the idea is the same. So in this example, we start out with, at time 0, with 74 patients. And of course, at time 0, no one has died and no one is censored. So the probability of survival at time 0 is 1, and the cumulative probability of survival is also 1. So then at the next time interval, in this case, say month 7 or year 7, whatever the unit of time is, we still have 74 patients in the analysis, but there's 1 death. And so now our probability of survival is 1 minus 1 over 74, or 0.9865. I'm carrying it out to 4 places here just to show the difference. And so then our cumulative survival rate is just the previous cumulative survival rate times the probability of survival at the next time interval. And so that's, in this case, that's just 1 times 0.9865. And so at time 7, our cumulative rate is over 0.98. And so this continues on. So at the next interval, at month 11, now because we've had 1 patient die, we only have 73 patients in our pool to analyze, and we have out of the 73 another death. And so the probability of that death is 1 minus 1 over 73, or 0.9863. And so then our cumulative probability of survival is just the previous value, the 0.9865 times the current probability of survival, 0.9863. And so we get 0.973 in our cumulative survival curve. And so this is how it continues on down. So in the next interval, we'd have 72 and we have another death. And so you keep computing the cumulative probability of survival in the same way. And I won't, go through each one. So at 25 months here, we have no deaths. So the probability of survival is 1. Oops. So we get the probability of survival is 1, and then 1 times 0.85 gives us the same cumulative probability at time 25 as time 20. And so we then plot the cumulative survival rate. And so this is an example from a study we did a while ago, where we have 2 groups, one that got chest radiation and another set of patients that didn't get chest radiation. And so we plot the Kaplan-Meier survival rate for each one, and then we can do a test of whether there's a difference between the survival functions. This is not a test at any one point or any one time. It's a test of the overall survival functions between the two groups. And so you get the Kaplan-Meier cumulative survival function there, and you can see this. It's the stair-step kind of nature. So in the situation where we have composite outcomes, and so some examples of those are oftentimes in papers, they're referred to as MACE. That's major adverse cardiovascular events is what it stands for, or MACCE, cardiovascular and cerebral vascular events. So they're combining different cardiovascular events here as their outcome. And so, for example, we might have cardiovascular death, non-cardiovascular death, non-fatal myocardial infarction or stroke, or say the outcome of interest is time to revascularization. And so I want to give an example here from the COURAGE trial, which is a trial that looked at the difference in clopidogrel treatment versus non-clopidogrel, and that's a trial that occurred some 25 years ago or so. But their composite outcome was cardiovascular death, non-fatal MI, and non-fatal stroke. So what's the problem in doing this, in combining outcomes into one event? So the issue is that the particular cardiovascular outcomes may be competing risks for the other outcomes in the multiple outcome event or variable. And so the issue is that they may have different survival distributions. And if you're doing multivariable analysis, then the covariates might have differential effects on the event types. Now, if you analyze each one separately, then you have the issue of multiplicity, as well as the fact that subsequent analyses are likely to be underpowered. So in the case where we have competing risk, as I gave an example before, maybe we have our outcome is cardiovascular death, but the patient dies from cancer. And so at that point, they're no longer at risk for cardiovascular death. And so how do we handle that? And in the way that we're going to, then the methods that we're going to look at, death from any other cause might be a competing risk of cardiovascular death. And in the example of kidney failure, end-stage renal disease, if you're looking at death, then death from any other cause could be a competing risk. Or if you're looking at time to have to go on or get treatment for it, then if you die before you receive the treatment, then death is a competing risk. And so what the methods that we're going to look at here are event of interest. When we look at each one in combination, is going to be called the absorbing state. And so let me give you an example here of a study that we did a few years ago of atrial fibrillation in hypercardiomyopathy patients. And so obviously in this, we're looking at, we're going to use Cox proportional hazard regression. And in this case, obviously death from any cause is a competing risk for atrial fibrillation. So there is a method of analyzing these data by Fine and Gray. And what we did that use this in a couple of instances, but we looked at time to the first event, because obviously AFib, you could have more than one AFib event, but one of our analysis was just to look at the time to the first event. But the fine and gray method is commonly used for competing risk, and it's part of any survival package in the major statistical packages, SAS, Stata, you can do it in R. But the thing about the fine and gray method is that the deaths, the competing risks are never sent, whatever the competing risk is never censored. So in other words, as you do the analysis, the deaths, whatever the time of death is remains in the calculations of the cumulative survival rate. So this is one way of handling competing risk. Another way is just to those that die before their AFib event is just to censor them at death. Just do the, sort of the regular Cox model with censoring at death. And so what we did is we wanted to compare the results from using the fine and gray method versus just censoring patients at death, like you would censor them for any other dropout or loss to follow-up. And so what we're going to do is we compared the models looked at the regression coefficients, and then use the information criteria results as well, the Akaike's and Bayesian information criteria. So this is for one of the data sets that we had, and so we did the analysis using competing risks, the fine and gray method, and then compared that with what we got when we did just the censoring at death. In other words, no competing risk. And as you can see, that the difference in coefficients is very small. There's no difference that's even 0.1 or greater. And so our conclusion was in this case that since there was little difference across all 10 data sets, because we did multiple imputation of missing values. So we did this comparison for all 10 data sets. And so as you saw in the previous table, many of the parameter values differed only in the third and fourth decimal places. And so what we did, we just used for our final analysis, just censoring patients at their date of death. Now, this is not to say that you can always do that. Likely this happened in our HCM data set here because the death rate was very low, only 0.9%. So that might be a reason why the difference in the model, the fine and gray model and the censoring at death model were essentially the same. So in competing risk, what we're going to look at is another way of analyzing the data called multi-state models. And so in the diagram here, you have the initial state where everybody starts in, there's no event. And then we might have the event of interest occurring or the competing event occurring. And so what we're going to do is we're going to calculate the cause specific hazards for each event, the event of interest and the competing event, or events as the case may be. And that's represented by the alpha sub t cause-specific hazard at time t. And so here's a more complicated model where we have more than one competing event. And so we start out our initial event, then we have the hazard function of competing event 1 and the hazard rate of competing event 2. Then you can see that the way that the arrows are drawn here, that you might have competing event 1 and then eventually have the event of interest, whatever that might be. Or you might start out at the initial state and then experience the event of interest, the absorbing state, without either competing event occurring. And then, so it might be possible, and I didn't put them in there because it got too visually hard to see when you put the other hazard functions in there, but you can see that we would have a hazard function for going from competing event 1 to competing event 2. Now, in the cardiovascular field, obviously, whatever event you have, there's no return to the initial state. But in some contexts, that's possible. So, for example, if we're looking at, say, ICU infections, and so in our initial state, everybody starts out with no infection, then they get an infection. But obviously, then in terms of the follow-up time, it might be possible that they once again have no infection. They're back to the initial state, and that's what's represented by the dashed arrow. So in terms of the cause-specific hazards, we're going to assume that each cause-specific hazard follows a Cox model. And so these are just the formulas here, from time 0 to time t, and the cause-specific hazard that you would have for each event type. And then the second formula there is if you add in a vector of covariates represented by capital Z. And then so in terms of the calculation here, it's just the observed number that transition to time at the next time t sub k, and then it's divided by the persons at risk just prior to time t sub k. So that's the software does all this for you. So, but this is what we're doing. So I want to give an example here from the CREDO trial. Again, this is a really old study, but this is looking at clopidogrel and just placebo versus ASA, aspirin alone. And so this study enrolled over 2,000 patients. There were 1,053 in the clopidogrel group and 1,063 in the placebo group. And it was a multi-center study. And so in this trial, the primary outcome was a composite of cardiovascular death, non-fatal MI, or non-fatal stroke. So here is our table of demographic and clinical summaries of the trial. And so for the demographic and clinical variables, you can see that there's no difference, which is what you should observe in a randomized trial. And then in terms of the outcomes, you can see that the composite of death, MI, or stroke was statistically significant. However, any one component of the composite was not. And again, as I mentioned before, the issue here is that you have multiple, if you're doing each one individually, then you have the problem of multiple testing and the increase in the alpha error rate. So in terms of analyzing these data, this is the cumulative hazard that was published in the paper on the composite event. And so you can see that the clopidogrel group has a absolute 3% difference in the rate of the composite outcome. That translates to a 27% relative risk reduction. And that was statistically significant. But as we might want to then look at the components, the particular components rather than the composite. And so, as I mentioned, often this is done by analyzing the components separately. And oftentimes they, call that a secondary analysis. So in terms of the competing risk model, we would have this sort of diagram where our competing risk would be non-fatal MI and non-fatal stroke, and our absorbing state or the would be cardiovascular death. And so if we analyze each individual outcome, this is what their cumulative hazard rates would look like. And from this, we can sort of tell, we can make a guess about which is playing the major part in the analysis of the composite death, stroke, and MI together. And you can see that the long dash is the non-fatal MI. And so we can see that the cumulative hazard rate is quite a bit higher than it is for cardiovascular death and for stroke. Although in all three cases, the blue line is clopidogrel, is a placebo. The black is the clopidogrel group. So you can see that for each case, the clopidogrel group is doing better than the placebo group. But this would be what, if you plotted all three cumulative hazard functions for each component. But in terms of doing a multi-state model, what we want to do is look at it in terms of non-fatal MI and non-fatal stroke being competing events. And so we get, for a multi-state model, this sort of diagram where a patient would maybe go from no event to a non-fatal MI and then die from a cardiovascular event later on, or they might experience cardiovascular death without experiencing either competing event. And I put the dash line in there because that would be a possible way that a person could go to one competing event to another, but that having a stroke, non-fatal stroke, and then having a non-fatal MI didn't occur in the CREDO trial. But experiencing a non-fatal MI and then a non-fatal stroke did. So that's why the diagram looks like that. So if we look at then the cumulative hazard rates based on the competing risk hazard functions, then it would look like this. So the black line is going from a non-fatal MI to cardiovascular death, and the orange line from a non-fatal or the going from a non-fatal MI to a non-fatal stroke. And so you can see that in both examples here that the clopidogrel group is doing better. But here we get, and we could also have plotted the non-fatal stroke to cardiovascular death, but those were very small, so I didn't include them in this graph. But in this case, doing the multi-state, we actually can confirm that a non-fatal MI is the major driver of cardiovascular death. So those that transition from an MI to death are obviously at the greater risk. And in terms of the data, the transitions from having a myocardial non-fatal MI to CVD to a death actually occurred with just in a few days of following treatment. So in terms of just looking at the raw data versus the analysis, it's like, well, that's sort of confirming what we would conclude. But the bottom line here is that competing risk and a multi-state analysis provide more information on the survival distributions of the event and their impact on each other, rather than analyzing each one separately. So I want to just talk a little bit about the way that data would be entered, regardless of the statistical package you use. And so you can see that the way that that you enter data is that you might have multiple observations for any given patient. And so, for example, patient one, they enter at time 0, they exit at time at 1 month. And so then from 0 to 1, they have a non-fatal MI. And then we have the same patient who experiences a cardiovascular death. So in the next observation for that patient, they're entering at time 1 at 1 month. And then at 13 months, they experience a cardiovascular death. So we would have their enter and exit for each event. And so, for example, patient number 2 enters and then exits at 12 months without any events. So they just they have just one line of one row of data, and then patient number 3 would be an example where they have all 3. So they have a non-fatal MI at 3 months. Then at 7 months, they have a non-fatal stroke. And then at 10 months, a cardiovascular death. And then patient 4 is just the example of where a patient begins is in the initial state, and then at 12 months, they experience a cardiovascular death without experiencing either an MI or a stroke. So in terms of setting up your data, this is the way that it would be set up. And I'd say this is the way you'd set it up for in any statistical package that you would use. And so you can see that in the column there titled from, you have a code for the different events. And so 1 is a non-fatal MI, 2 is a non-fatal stroke, and 3 is the absorbing state or the cardiovascular death. So you have a row for each event for each patient. So if they have multiple events, each patient will have multiple rows of data, and then you need to designate what event they have at that particular time. Okay, so I just listed some R functions here that would be used in doing multi-state analysis. As I mentioned, the survival analysis you can do in any statistical, the regular statistical or regular survival analysis you can do at any statistical package. I'm not sure about doing multi-state analyses. I don't think that's available in Stata. I don't know about SAS, but it's something that you can relatively easy, relatively speaking, to do in R. So I want to then list, I'll have a list of some references here that discuss regression, Cox regression, as well as competing risk in multi-state models. The last two, the Byersman book and the Royston book, are probably the most easy to read and they actually have, I believe, R code R code examples. So those are the two that would be most interesting or probably most beneficial to use. So we're done a little bit early here. I want to thank you for your time, and then so if there's any questions that you have, and I will send these slides to the folks at Georgetown, and then for those who are registered, they will make those available to you, as well as the presentation on, I believe they put it out on YouTube. So I'll stay around for a few minutes if there are any questions. Otherwise, thank you for your time and attention. The question is there a proportional hazard assumption in multi-state model? Yes, there is, because you're using the Cox model, so you would have that proportional hazard assumption. If there's not proportional hazard assumption, then it's going to get more complicated, because then you're going to have to look at say what variable is in multivariable analysis, what variable is causing that violation, and then usually what you do is you have to then stratify on that variable, which obviously is making the analysis more complicated. if you think of questions later on, or want some more information about multi-state models, feel free to email me at my MedStar account there. Okay, if there are no more questions, I again want to thank you for your time and attention, and we will again meet in November.